Good afternoon, everyone. My name is Niamh McCormick and I'm a clinical nurse manager here with COPD Outreach in Beaumont Hospital. And I'd like to speak to you about COPD from a nursing perspective and what to expect when you come into hospital. You all know your bodies better than anybody else will know it, okay? I know my colleague spoke about being aware of your level of breathlessness at rest and signs and symptoms that something is going wrong. Could be the sign that that you've started to cough more, especially at night time, and that it's keeping you awake, or that you've started to produce sputum, or that your sputum production has changed. You could be somebody that produces quite a bit of sputum, but you don't produce any, or it's that thick now that you can't actually cough it up. So that would be abnormal for you. So that would be a warning sign. Other people would say that they feel that they're getting a bit short of breath, that normally they can walk up the steps or the stairs at home, but now they have to stop on step 10. Well, that's a warning sign. That's also a trigger. You say, well, you have to be aware of this. Things like developing a wheeze, which isn't normal for me. And a wheeze simply means, if you think of a pipe organ, the low notes are where the pipes are wide and the high notes are where the pipes are narrow. So it means that there's swelling going on inside in your chest. So if you start to wheeze, that's again abnormal for you. So that's a sign that there's some inflammation going on in your lungs. If you feel that your normal medicines that you use to relieve your symptoms aren't working, then that's a time where you should initiate your plan A. And also that you have decreased appetite. One good thing I can say about COPD is that exacerbations of COPD run true, meaning that what happened the last time will happen the next time, will happen the next time. Your warning sign the last time will be the same the next and the next, whether it is I get short of breath when I get to step 10, or I normally produce a little bit of phlegm, but it's gotten so sticky that I can't bring it up. Or I kind of go off my food and 2 days later I'm sick. Somebody else might say, I feel like I'm carrying a backpack, 2 days later I'm sick. That's your warning sign. That's when you initiate your plan A, whether it be to start using your extra 2 nebulizers. Then when you have a second symptom on top of that, that's when you go to your plan B, or you instigate your rescue prescription. Just some signs and symptoms that are an emergency. You actually have a roaring temperature, but you feel that you're cold and you're shivering. And that's called rigering. And you probably see it in children that when they get a really, really high temperature and they can't control it, they actually convulse. With adults, what we do is we rigor, but we feel really, really cold. And that's kind of it's an emergency sign. You really do need to get into hospital to get that dealt with. Another one would be that you look cyanosed, which is a colour that we would say is a bluish tinge. So you would be your nail beds, the tip of your nose, okay, your lips, the lobes of your ears, and sometimes we would even say if you look in your mouth that the inside of your oral cavity would be a little bit on the bluish colour. And that's a preservation tactic that your body has, because your body is going to say, okay, my peripheries are not that important to me, but my brain and my heart and my lungs and my kidneys and all the things that are hidden in here need to be preserved. So it will feed them the oxygen and forget about your peripheries. So if they're starting to change colour, that's a danger sign, and you really need to go to hospital. And then the other danger sign, again, this would be more for the family, would be that you're actually extremely drowsy, to the point that you can't hold a conversation. You're falling asleep mid-conversation, you're falling asleep mid-meals, or you're sleeping a lot of the time, again complaining of, which can be described as you would think somebody just hit you smack bang in the forehead with a hammer. They can be signs that your carbon dioxide levels are climbing, and that can happen when your oxygen levels are depleted as well when you're having an exacerbation. So that's an idea, a point where you really, really do need. It's a 999 job. It's not I'll wait in the morning and see if the headache goes away, or I'll wait in the morning and see if these shivers go away. It's definitely into hospital now. No dilly-dallying, no waiting. Things that will happen when you come into the hospital. All right, the first thing that'll happen, certainly if you come in an ambulance, is you'll be given some oxygen. Oxygen treats low oxygen levels. So you will always be given the lowest amount of oxygen, all right, to keep your oxygen saturations between 88 and 92%. The reason for this being is people with COPD live on a thing called their hypoxic drive, all right? In simple terms, your body is not getting rid of its waste air. Because your body holds on to a lot of waste air, your body is very used to having high levels of carbon dioxide. So your body says, Neve, your oxygen levels are low, you need to breathe in. So if I'm flooded with oxygen, my body will go, great, I have enough oxygen, I don't need to breathe. And unfortunately what happens is people can tip into comas if they get too much oxygen. So we really will give you only the smallest amount. Please make sure to ask them in the hospital that they give you an air-driven neb, which is like a little compressor, and that you're not given your nebulizer through the oxygen on the wall, because they will give you up to 7 litres of oxygen, and really 2 to 4 is sufficient for anybody with COPD. Oxygen has a very drying effect on your oral and nasal mucosa, as anybody who's on oxygen might tell you. So if that's the case, then you really need to ask your nurse to get you something to try and alleviate that. We wouldn't use Vaseline because that supports combustion, like oxygen supports combustion. So we would probably use something like a KY jelly or something like that, something more water-based to help relieve that sensation. Your oxygen can be humidified as well. You might see some people in hospital with the oxygen's bubbling through a little bit of water. That's just to moisten it so it's not as irritating or drying on your nose. But if that's a problem, please do say it to the nurses. While you're in hospital too and you're on oxygen, you may possibly have a little peg on your finger, and that's called a pulse oximeter. It's non-invasive, there's no needles, there's nothing stuck onto you, and that literally simply just takes a snapshot of how much oxygen is getting around your blood. Medications then, nebulizers. As I said, ideally people with COPD, when they're in hospital on a hospital stay, they should have their nebulizers given by an air-driven nebulizer. Unfortunately, sometimes on the way in via an ambulance or in the early stages of assessment then in A&E, you may actually be given your nebulizers via oxygen, but you're in the right place and we can sort it out. But if you're going to be in for a long time, please do say that you want an air-driven nebulizer. There's 3 different things that we would give you in a nebulizer. One would be an antimuscarinic. What it does, it dries up all that phlegm, that sticky stuff, but it also widens up your airways. All right, and that would be a thing called, say, Atrovent. We would also give you a bronchodilator, which is a medicine that widens the airways, so lets the air pass in and out a lot freer. A combination of a bronchodilator and an antimuscarinic would be Combivent, and a lot of people know Combivent, they're on Combivent at home. And then the other thing that we would possibly give you in a nebulizer form would be a steroid. And that would be if you weren't physically able or you didn't have the inspiratory effort to be able to take your inhaled steroid inhalers, and we sometimes would give you a nebulized steroid. Nebulizers, as I said, are always air-driven. If you have COPD, as too much oxygen, it can make you quite ill. And if you do have your own nebulizer at home and you are blue lighting it into hospital, if at all possible, or even if you're coming in a car, please try to bring your own nebulizer with you. Initially, when you come in, if you're particularly wheezy, you'll be given your steroids in IV form, and you will get quite a high dose. Now, I know that people have been saying here today that at home that you may get a prescription of 20 to 30 milligrams, which is 4 to 6 tablets for about a week and then stop. If you come into hospital and they give them to you IV, they give you 100 milligrams 4 times a day. Okay, so you're getting 400 milligrams. So you're getting like 8 times the amount that you would get if you were at home. So generally what we do after being on those levels is that you would have a slow wean. So after a couple of days, if you're not particularly wheezy anymore, they will change it over onto tablet form and it will be weaned down slowly. The reason for that being is we have little glands on top of our kidneys called our adrenal glands, and they secrete adrenaline, which you've heard of as your fight and flight hormone, but they also secrete cortisol. They also secrete steroids, our own steroids. And if we give you a lot of steroids artificially, these guys, because you're not well, sit back and they have a little bit of a rest. So if we were to give you loads and your body's not making any, and then we suddenly stop, your body will go into shock, and we call that an Addisonian crisis, and that's actually a medical emergency. That's an ITU admission. Your body goes into crisis. So what we do when you had high doses like that, in general, is that we would wean them down slowly, so your body kicks in and it starts making its own steroid again till it's on a par, and then these can drift off, and your body has started producing the right amount of cortisone itself. Okay, so that would be one of the reasons after being on IV steroids that you would have a slow wean. We would say to try to complete the course out. Ideally, when you go home, you shouldn't have 3 or 4 tablets rattling around in a bottle after 2 weeks. You should really complete out the course. Some signs and symptoms then are side effects from steroids would be they can increase your appetite, which isn't a bad thing, because the first thing that goes when you're not feeling great is your appetite. So they can make you ravenously hungry, and your body is using up so much energy to try and heal itself that you're going to need that extra reserve. So eat as much as you can, okay? They can make your hands and your face and your feet swell a little bit. And sometimes if you see people that have been on steroids for a long, long period of time, as in tablet form, they get a really round face, like a moon face. And that's basically from being on steroids for a long, long time. They can cause really bad irritability, Jekyll and Hyde irritability. But it is only the medications, and once the medications are weaned back down, you should be back to your old self. Irritability, restlessness, and insomnia. So people that are on steroids would say that they're not sleeping. So we would ideally ask people to take them in the morning time. So have your breakfast, make sure you're something in your tummy, because it can be quite hard in your tummy, and have your full dose of steroids. All right? So if you're on tablets, you're going to have your 6 tablets or your 8 tablets there and then. Don't pace them out over the day, because you'll just be bright as the button at night and you won't be able to sleep. Other things that they can do then is they can cause your body to leach potassium, certainly when they're in very high doses when you're in the hospital and they're on IV. So what the doctors will do is that they will do a blood test every 2 days just to check what your kidney function and your blood salts are like. And if it's a case that your potassium is falling, and you need your potassium for a healthy heartbeat and stable heartbeat, they will replace it. You might either get it in IV form or in tablet form. And then the other thing that they possibly can do is increase your blood sugars. Now, it doesn't mean that you've become a diabetic, but when you're on steroids, the nurses in the hospital most definitely will check your blood sugars. What they would do is give you insulin until they can wean them down. And they would wean them down, obviously, a lot faster, but it wouldn't be a case that they would suddenly stop steroids. It does not mean you're a diabetic. It's just steroid-induced, okay? And once the steroids are gone, those high blood sugars are gone. Usually when you come into A&E, you're given a broad-spectrum antibiotic, all right? That's an antibiotic that kills both anaerobic and aerobic bugs. Anaerobic bugs are bugs that don't need oxygen to live, and aerobic bacteria are bacteria that need oxygen. Over the course of your stay, you may have your antibiotic changed, and that's because you could have given us a sputum sample, we've sent it to the lab, we've got cultures and sensitivity on it, and we know which antibiotic is the right one to try and eradicate this bug. Again, they can be given either intravenously or in tablet form. Usually if your white cells are up, your cells for fighting infection, if they're high, we will usually give them to you IV, because it seems like your body's been trying to fight this. So we'll give them to you IV. They'll be changed to oral over the course of time. Usually 7 to 10 days of antibiotics. Again, it's really, really, really important that you do not have 3, 4, 5 antibiotics left, because unfortunately what we have seen and my colleagues have seen is people go home after about 6, 7 days, they feel fine, they feel well. 3 or 4 days left of antibiotics, I'm grand, I don't need them. Unfortunately, what we've done is we've kind of buried the infection, but we actually haven't hammered it home. And what happens then over the course of a week to another 10 days is this thing evolves and it becomes immune to the antibiotic that it was just treated with. And then when the person comes back into hospital, we have to bring out the big guns as regards antibiotics, and it's much more difficult to treat. So nursing at a ward level, when you're on the wards, certainly when you come in first, you'll have your vital signs checked very regularly. It may be a case that the nurses will keep you up beside the nurses' station, certainly if there's issues with your oxygenation. They will check your vital signs, they will check your temperature. They will certainly stand at the end of your bed, and it's not something that most people know, and listen to see if they can hear a wheeze from just speaking with you, and we would be recording that as an audible wheezing conversation, and that's something that would be something that we would use as regards whether somebody needs to kind of stay on IV steroids or can be changed to oral. Some people would also have that little pulse oximeter on them. If it's a case that we're having trouble oxygenating you and keeping your oxygen levels high, it may be a point that we'd have to get that uncomfortable blood test done. And unfortunately, the reason it's so uncomfortable is we're trying to get blood from an artery. And arteries come straight from your heart, okay? So they're under high pressure. The blood in them is under high pressure. And to protect them, your body buries them deep in beside the bones. And in order for us to get that blood test, we have to go down into that artery. And I know it's uncomfortable, but it is a necessary evil because it really does dictate which way you're going to be treated as regards the next step in treatment. The nurses might actually check your intake and output, and that could be a case that they will check everything that you drink and everything that you put out, just to make sure that you're not getting dehydrated. Another way that they've been more commonly doing this now is that they actually weigh you every day. And they'd weigh you at the same time every day, usually 6 o'clock in the morning, which isn't great really when you've probably just gone to sleep. But it's a really good way of knowing whether you're holding on to fluids, because sometimes too, steroids can make you swell. Blood sugar levels, they would just be a tiny little pinprick. I don't know if anybody's ever had a blood sugar level done, and it's just to check that the steroids aren't affecting your blood sugars and causing them to climb, which can have a debilitating effect on your other organs. So we would treat you with insulin if need be and wean them down as quickly as possible. Peak flow is where they get you to blow really hard into a device that measures how much air you can get out in a second before your nebulizer and then again after your nebulizer. You have chronic obstructive pulmonary disease. You have obstructive pulmonary disease. It's fixed. It's not going to change. Giving you a bronchodilator and asking you to do it again, it will make you feel a lot freer, but your obstruction is fixed, okay? The medicine can't change that. It can make you feel freer, but it can't change the damage that's been done, okay? People that have asthma, if you do a peak flow, give them the medicine and they do the peak flow again, there's a big difference. They don't have a fixed obstruction. So to do a peak flow, certainly when you're not well, it's extremely uncomfortable, and it'll also start you coughing. So if anybody asks you to do a peak flow, please tell them that there's no need for me to do a peak flow. A couple of investigations you may possibly have when you come into hospital. First is pulmonary function testing. And that's more or less kind of what I was talking about there, peak flow, but it gives us way more information. But I'm sure you've had this done where you go downstairs to the girls and you sit in a little car and they put a peg on your nose and you have to breathe in out through this tube and you have to take a big breath in and then you have to blow out as if your eyes were going to pop out of your head. Okay, and what that does is it measures the amount of air you can get out in 1 second, and it measures the amount of air you can get out all together in the blow. And if we take one or divide one by the other and it's under 70%, it means that you have an obstructive condition. And that's how we diagnose COPD anyway, is pulmonary function testing. Next one would be an ECG, which is a tracing of your heart. Anybody over the age of 35 that comes into A&E in this hospital automatically has an ECG done. It doesn't necessarily mean that there's an issue with your heart, but certainly if you're short of breath and your oxygen levels are low, it can have an impact on your heart muscle. So they would check that as well. Chest X-ray, which is a two-dimensional picture of your chest. Your bones look white and air looks black, and infection would look kind of a hazy kind of colour or like foggy. So you'd probably sometimes see chest x-rays up on the walls, all right? So any kind of patchy white or foggy kind of appearance on a chest x-ray is usually an indication of a chest infection or pneumonia. Blood test then that you would have done, definitely done down in A&E, would be your full blood count, or CBC, and that would be to check your white cells really, to see if there's a big infection there. Urea and electrolytes, which are your salts, to check that you're not depleted or your kidneys are working okay. CRP, which are D-dimers, and they're bloods that check what your inflammation levels are, to see if there's a lot of swelling and inflammation going on inside in your lungs. CT scan, I don't know if anybody's ever had a CT scan, but it's where we get better imagery. We get slices of your lungs going up this way instead of a 2D picture, okay. Can be a little bit scary, but the guys are very, very good. You can speak to them. You lie on a table and there's like a big circly donut that moves around you up and down. It's not, you don't feel anything, there's no pain, it's not invasive, and this thing, there's a little magnet in it that whirs around all the time and it takes different pictures. And we get a really, really good idea. We can, from your feet up, we can look up in through your lungs and see if there's certainly things like clots or pneumonias, things like that. It gives us a much better picture. And then the ABG, which I've spoken about already, which is the arterial blood gas. We call down to A&E every day. And if you fit our inclusion-exclusion criteria for going home, which is set by the British Thoracic Society. We have guidance by the British Thoracic Society, and we also have clinical governance by Professor Costello. If you fit our criteria, what we will do is we will ask you, do you want to go home? And if it's the case that you agree to go home and the doctors feel that yes, it is okay and it's safe for you to go home, then we will come and we'll see you at home every day for 3 days, and then we'll see you again at 2 weeks, and we'll see you again at 6 weeks. However, it's driven by you. And if it's the case that you need to see us on day 1, 2, 3, 4, and 5, well then that's the way it'll be until you're comfortable at home. Again, we discharge you back to your GP at 2 weeks, we follow you for 6, but you're forever and a day linked in with us. So if there's an issue or a problem, the GP can ring us and we can try and avert you coming back into hospital again. All right, so we can call out, if say for example the GP puts you on an antibiotic and steroid at home, we can call out and check whether that's working, and if we feel that it's not, then obviously we can trigger an admission to hospital.